Hi everyone, my name is Kambiz Ranavardi, co-president of ColumbiaDC and a graduate of School of Engineering and Applied Science. I would like to thank our partners first at Yale, Harvard, and Princeton clubs of Washington, DC, and their members for joining us in this gathering. We are honored to have Dr. Robert Klitzman, Director of the Graduate Program in Bioethics at Columbia University, to discuss how administrators of public health are dealing and should deal with the adverse public opinion. We are also fortunate to have Dr. Ellen Fox, founder and president of Fox Ethics, as our host. So please allow me to briefly introduce our speakers. I would encourage everyone to visit our event page for their full bios. Dr. Robert Klitzman is a professor of psychiatry at the College of Physicians and Surgeons and the Joseph Mailman School of Public Health, and the director of the online and in-person bioethics master's and certificate programs at Columbia University. He's the author of several acclaimed books, including The Ethics Police, The Struggle to Make Human Research Safe, and the most recent one, Designing Babies, How Technology is Changing the Ways We Create Children. And that is, in fact, what we will be pursuing as a future program on this very topic. Links to these and several other books by Dr. Klitzman are on our event page. So please go check them out. Dr. Klitzman served on DOD's Research Ethics Advisory Panel. He's a distinguished fellow of the American Psychiatric Association, and he received his AB from Princeton and his MD from Yale. For our host, Dr. Ellen Fox is a bioethics consultant, educator, researcher, and policymaker. She specializes in developing innovative approaches to complex social problems and managing systems-level change. Previously, Dr. Fox served as director of National Center for Ethics in Healthcare, where she served as principal advisor for the Undersecretary of Veterans Affairs for Health and was responsible for national policy and education on ethics-related matters. Recently, Dr. Fox's consulting work has been focused on advising organizations on back to school and back to work COVID plans. She received her BA from Yale, MD from Harvard, and completed her internal medicine residency at Yale.
Again, thank you all. COVID obviously is something that many of us are dealing with. And I think one of the points for tonight is to talk about why there often is a tension between public health and public opinion. And I would say that in general, a major problem is that there is often a misunderstanding of public health. So there are times when, even though we as a country very much obviously believe in freedom, individual freedom, freedom of choice, at times in the interest of public health, we need to, unfortunately, curtail individuals' freedom. And this obviously is a very sensitive and very controversial area. So for instance, we say with secondhand smoke that I may want to go in a bar or restaurant and smoke cigarettes, but we now have laws that say in most states that no, I'm not allowed to light up a cigarette in a restaurant or bar because there's secondhand smoke, which is going to affect the health of other people. I think we have Ellen back with us now. So secondhand smoke, for instance, is an example where the danger to others leads to needs to curtail individual decisions. Similarly, Oliver Wendell Holmes, making perhaps one of the most famous comments the Supreme Court ever made, said that basically my freedom of speech ends at the point at which I yell fire in a crowded movie theater. In other words, as soon as my liberties begin to directly affect another person's health, my liberties, unfortunately, in a society, in a civil society, need to be curtailed. Similarly, with seatbelts, for instance, I may not want to wear a seatbelt, but laws are that everyone has to wear a seatbelt. And the reason is because we know that if people don't wear seatbelts and they get into severe accidents, they may end up in intensive care units or hospitals for years and years and years, costing society millions of dollars. And so we've decided as a society that that is too big a cost to have, that we need to say that everyone needs to wear a seatbelt. So similarly now, obviously with COVID, as we'll talk about, there are points at which we sometimes need to say that even though you don't want to wear a mask and you want to go outside, that those are things that we need to restrict, that you need to either stay inside in general, or if you've been exposed, or you need to wear a mask if you go outside. And when I just started and addressed the initial comments that I thought would get us started.
Well, thank you so much, and I apologize to everyone for the very unfortunate timing of that loss of signal. I have no idea what happened, but I guess that's the way these things work sometimes. I wanted to begin by thanking Camby's for your leadership in organizing this, and I know it's really not an easy thing to do, and you deserve a lot of credit, you and your team. I don't know if you talked yet, Bob, about the fact that you and I are both bioethicists, and some in the audience may be wondering, with regard to our topic to get today, why bioethics? You know, people are probably aware that the field of bioethics focuses on ethical issues in medicine and biomedical sciences and other health-related sciences. And at its heart, it's about figuring out the right thing to do in situations where there's uncertainty or conflict about values. And these are, you know, really fundamental things that are important to us, either as individuals or as organizations or as a society. So it sounds like you have given a little bit of background about the fundamental tension in public health. Between advancing the health of the community versus protecting our individual civil rights and liberties. But it's not really an either or, is it? It's not, you know, do we value individual rights and freedoms, or do we value the health of society? That's often the way these issues are framed when there's a conflict, but you know, it's really a false dichotomy. You may have already said something like that. I'm thinking of this ethicist named Rushworth Kidder, who writes books for the general public, and he makes the point that ethical dilemmas are often not choices of right versus wrong, as people may think of them, but choices of right versus right. So we value both the rights of individuals and the health of society, but there are trade-offs. So in creating sound public health policy, we need to figure out, you know, where to draw that line on particular issues. How do we draw that line, or to be a little more precise, what is the role of bioethicists in this? What do bioethicists do to help figure out where to draw that line, particularly on public health policy questions?
Right, great question, important question. So in general, very briefly, there are certain basic principles that we in bioethics think are important, sort of as heuristics, so to speak. One, obviously, as we mentioned, is individual rights, autonomy, but also we look at the benefits to an individual, to a society as a whole. We look at risks, harms that may occur, and we try not to increase the gaps between the haves and the have-nots. We're concerned about social justice. So in the case of COVID, for instance, obviously respect autonomy, but the point at which one person's autonomy is going to clearly endanger other people's health, we need to factor that in. Now, and to say that we therefore, for an example, need to reduce someone's autonomy. We're not going to lock you up necessarily, but we want to encourage you at least to wear a mask, or maybe you can't go in the store. You could walk around outside without a mask, but if you go into a store, you need to wear a mask. So we want not to take too much autonomy away. We want to make sure that there's clear and sufficient benefit. We also want to look benefit for whom, for how many people. Of course, we'll talk about this with vaccines, with testing. You end up with not just benefit for one person, but for many people. How do we weigh these things, et cetera? So with vaccines, some people may not want to vaccinate their kids for mumps and measles and rubella, and states have a hard time saying at what point do we say the parent has a right to say no versus there's needs to protect the population. So if only a few parents say no, we let them and we get everyone else vaccinated. We rely on autonomy. We don't say you know, if you don't vaccinate your kid, you're going to be locked up. So we try to not decrease individual rights too much. We try to maximize the benefits as much as we can, reduce the risks, et cetera.
So I'm reminded in our field, we often say good ethics begin with good facts, you know, and so bioethicists tend to be good at collecting information. We tend to be good at assimilating information and analyzing, and, you know, and we study up on whatever topic we're faced with, do a thorough review of available information. So a lot of it is about facts, because if you don't agree on the facts, it's really hard to resolve ethical issues. But equally important is, you know, in bioethics, we actively seek to understand and to respect various people's perspectives, because whenever there's an ethical issue, there's a values conflict by definition. So many ethical issues are difficult to resolve precisely because they are issues that reasonable people may disagree about, but we have to make decisions anyway. Right now in this country, there seems to be a tremendous amount of disagreement about public health issues, and not just about the pandemic. You mentioned some of these things. I mean, there's been a concerted effort to discredit the scientific consensus in many areas. We're really living in an era when all manner of scientific knowledge, from not just the benefits of vaccines, but the safety of fluoride in the water and climate change, and, you know, the list goes on, that these issues face organized and often very angry opposition to the science. So what do you think are some of the reasons why so many people are doubting science right now?
Right, it's a great question. So I think there are a few reasons. On the one hand, science gives us unwanted truths. In other words, we have competing desires. So I may want to make as much money as I can, and I have a factory, and so if there is toxic stuff coming out of my factory, just dump it in the water or put it in the air, and if I have to clean it up, it's going to cost me a lot more money. So if my goal is only to make money, the fact that there may be health risks to people is not something I really want to deal with too much. So there are, same with climate change. Obviously, there are companies or there are people who say, I want to, you know, use coal or make money off of coal or make money off of things that may lead to global warming or climate change. And the fact that it exists was going to get in my way. I'm going to have to use more costly procedures to create energy, for instance, if that's one of the issues. And I really don't want to deal with that. I don't really want to wear a mask. Masks are uncomfortable and they're hot and I have to carry it around. And if I forgot my mask at home, it means I can't go in the grocery store, and that's terrible. So the fact that I may need to wear a mask to protect myself or others, these are facts that, you know, are inconvenient truths, so to speak. So I think those are some of the issues. I think also that we've not done as good a job with science education as we can in this country. So for many people, science is something that they don't really understand. It seems unfamiliar. They didn't do well in it in school because it wasn't well taught. It's scary. And I think that goes into it as well. So the notion that science is a process, that it is an attempt to get at the truth, that there are many truths that science has found. People used to think that the sun goes around the earth. We then learned that no, well, in thousands of years for people to accept and believe that in fact the earth goes around the sun. This was upsetting to the church at the time and many people. So science is maybe counterintuitive in some ways. Mm-hmm. And yet, of course, we all have tremendous benefits. We would not all be here on this Zoom call, seeing each other, speaking to each other from all over the country if it weren't for science. And so science gives benefits, but is scary to people. I think we could teach it better by making it fun. And then, of course, I think there is an attack on expertise more generally that we can talk about.
Yeah, I mean, of course, many things in science are uncontroversial and widely accepted, but clearly some scientific topics, you know, facts have become really a subject of considerable debate. Right now, for example, there's debates raging over the effectiveness of hydroxychloroquine. the benefits of mask wearing, even the number of deaths due to COVID-19. And in each of these areas, I think it's safe to say that there's far more agreement among members of the scientific community, particularly the experts in the particular areas that, that's concerned, much more agreement than there is among members of the lay public. So what is really going on there?
So a great point. So a few things, I think. One, of course, is that people get information from various sources, and with the internet and social media, people get information from sources that often confirm their pre-existing beliefs or prejudices or biases. There's a phenomenon known as confirmation bias, where people actively look for, listen to only those things that support their opinion. So I think that's one major factor that's going on. And then I think also that leadership is important in these times in dealing with these issues. And so there have been leaders who have said that you don't need to wear masks. This is all a hoax. Don't worry about this. It's just going to go away. And again, I think that sows distrust among people, and it leads to people not believing what those nerdy looking scientists are saying. And you often have the case of years ago with the tobacco industry, actively, you have companies that have actively, and individuals who have actively attacked science, attacked scientists. And so I think these are all factors that go into that. I think there are competing political pressures. Some people just want, especially in election year, there are people who want to support their candidate no matter what, and science can get in the way.
Yeah, we, on that point, I think we do see this phenomenon where certain interpretations of facts or scientific beliefs become associated with a particular group identity, and it may be a cultural group or a religious group, but in the case of the pandemic, we're seeing strong differences in beliefs based on political identity, to the point where some people, I think, seem to have lost all faith in science and in scientific expertise, as you mentioned, and they just believe everything is political. So how do people's group affiliations, and particularly their political identities, influence how they process scientific information?
Yeah, so again, there's, as I mentioned, confirmation bias, and there have been studies that show that what people hear when you tell them a bunch of things, they'll remember the ones that confirm their own pre-existing bias or prejudice. I think another phenomenon is as people click on the internet, et cetera, Kahneman Tversky, Daniel Kahneman is a Nobel Prize winner at Princeton as a professor, and Amos Tversky died, was an Israeli researcher who worked with him. But Kahneman now wrote a book, for instance, Fast and Slow Thinking, a few years ago, how people have a quick, fast way of thinking. We evolve with this. If a tiger's running at you, you don't think, well, what am I? I have a 52% chance of getting up the tree, or a 38% chance of living if I run that way, and an 18% chance. You just immediately act. You have a gut reaction. Versus slow thinking is, no, wait a second, now what would be the risk of this and the risk of that? And research has shown that fast thinking is easier, it's simpler, it's more emotional laden, and people prefer to do it. Slow thinking takes thought, takes time, takes practice. And so our default position is fast thinking. And this is why I think, we, on both sides of the political spectrum, there are websites that are busy trying to increase their click rate and have emotional laden headlines that'll grab our attention and speak to us. And of course, once you're talking about emotions, you're not talking about intellectual thinking that is often needed to solve complex problems. And so you have people who are getting their information from their silo, from people they know who agree with them. It's confirming their emotional beliefs. And I think this, unfortunately, leads to polarization, but also can lead to rejection of science for many people.
I was just looking at this study from Pew Charitable Trust showing that there are clear differences of opinion about science based on political affiliations, and that since the pandemic, these partisan differences have widened.
Yeah.
And so, you know, in April, Pew asked how much confidence people had in scientists to act in the best interest of the public, and 52% of Democratic-leaning Americans said they had a great deal of confidence, compared with only 27% of Republican-leaning Americans. And this difference existed before the pandemic, but you know, the difference between the partisan divide has really dramatically widened. You mentioned this, you know, the confirmation bias, the tendency for people to cherry pick scientific information that reinforces their beliefs or interests, and to discredit information that threatens their beliefs. Interestingly, I read one study that said the more intelligent you are, the better you are at doing this. So I think sometimes we might assume that, you know, people that aren't educated, or people somehow are unsophisticated or something, are the people that challenge you know, facts or scientific consensus, especially in anti-scientific ways. But really, you know, maybe it's more people with a strong political interest or strong financial self-interest or other interests that tend to have biased interpretations of the facts. A lot of this is on display on the internet, as you alluded to. How do you think the internet and social media have influenced the way people view science?
So I think that it has exacerbated the issues that we're talking about, because most people will get their scientific understanding from the media these days. And unfortunately, there have reputable media sources, many of them have been under siege. So major newspapers have had less funding because people are getting information from the internet. Why pay for a subscription to a newspaper if you can get all free information online? And so there have been fewer science journalists working at major newspapers. I think also we don't train scientists themselves well in how to communicate science to the public. I think this is a major role that bioethicists can and often do play, is try to translate these complex scientific issues that have social, ethical, legal ramifications into a way that people can understand. I think it's an important function of what we do to increase scientific literacy, which unfortunately is low. And just as historical context, of course, this is happening now following decades of difficulties in this area. So of course, a large percentage of America believes that the world was created in 7 days. They don't believe in evolution. I don't remember the exact facts, but something like at least a third of Americans believe in creationism. There was the Scopes trial years ago, attacks on Darwin, etc. So I think that this is sort of a long populist trend that's now exacerbated. You said it's not just people with low education either, people with strong beliefs. And I think people obviously online and the internet no longer are clear necessarily on what is valid and invalid information. So it used to be, when I grew up, there were 4 major networks, and you know, that's where you got your news. And now there's, you know, flybynight.com that has, who knows who's starting it. There are bots, there are all kinds of false information out there, and science gets blurred. And I think this has been in some ways a conscious effort by certain groups to sow confusion among people, and they've succeeded.
Right. Yeah. You know, another thing I've noticed is that some of the rules of scientific review and publication have been suspended, or at least changed during the pandemic emergency. So for example, you know, drugs and tests are being authorized for use by the FDA that would never have been approved under usual circumstances based on very little evidence. And so they're temporarily approved, but then that approval is reversed, which I think confuses people. Papers are being published before they undergo peer review. So we've seen a lot of critiques and a lot of you know, retractions of papers, and papers are being made available to the public and disseminated by the media when under normal circumstances, you know, these papers would not be accessible to the public or to journalists because they're behind a paywall. So how do you think that changes like that have affected the scientific landscape, and especially public trust in science?
Yes, great question. It's had a huge effect, these various factors have. So on the one hand, the fact that you've had a lot of retractions among scientific papers. Interestingly, the number of retractions has been going up even before COVID. And of course, there have been notable cases now. And the reason, of course, is we're all desperate to get rid of COVID. I mean, everyone in the planet is arguably been affected in adverse ways. We can't socialize the way we used to. We can't teach students or learn as students the way we used to. We can't see friends, family, loved ones, etc. So we're desperate to get rid of this. This is an epidemic unprecedented in our lifetimes. It's akin to, you know, the Black Death, which wiped out 50% of parts of Europe. And we haven't seen the end of this yet, right? So there are going to be subsequent waves. So people are desperate. And so therefore we're rushing everything. Let's rush things into production. Let's rush publications. Let's rush vaccines. Hopefully we can rush things and not have them go awry. But unfortunately, as you know, science is a process, and often it takes a certain amount of time. When President Kennedy said in the early 60s, let's send a man to walk on the moon, it took till 1969 for that to happen. If he had said, let's send a man to walk on the moon by November or by next year, it wouldn't have happened. It was a stepwise process. Same with vaccines. There's a great urgency. Let's sort of hurry up and get a vaccine. Historically, vaccines have taken 10 to 15 years on average to develop. 86% of vaccines in phase 1 trials never get approved because they don't work. But because we're desperate, we've lowered standards. So the FDA has now said that it will approve any vaccine that works 50% of the time. Well, that could be good. It means that 50% of the people who get the vaccine may be helped, but 50% of the people who get the vaccine may not be helped. And of course, that then can lead to further mistrust of science. People saying, well, I got the vaccine and I still got COVID. We already have people who are anti-vaxxers, as I mentioned earlier, who say, you know, vaccines cause my child's autism, even though there's no evidence that that is the case. And in fact, the one study that showed that vaccines cause autism turned out to have been fabricated. It was all made up data. But people, again, through confirmation bias, et cetera, are looking for, quote, facts or evidence to support their views. And the problem is that we risk losing trust in science, as you say, if we rush things and papers get retracted because they're wrong, or we rush things to market that end up having severe side effects, or that are not effective. We're going to hurt ourselves in the long run. And so we need, I think, to have long-term perspectives, not just short-term perspectives, not just get any old vaccine out there, even if it ends up killing people and only works half the time. But we should try to get, well, I should say, we need to weigh that possibility against getting the best vaccine possible. Well, we may not want the perfect to be the enemy of the good, but we need at least to balance these things, as you say. And part of the problem in having good facts, as you say, which is important, is that unfortunately there's uncertainty involved here. There's uncertainty involved in science, where COVID is a moving target. We know much more today than we did a month ago and than we did 3 months ago, but there's still a lot we don't know. We're learning every day. And again, that makes it hard for people to trust science. There have been people attacking Dr. Fauci, for instance, saying, well, he said this at one point, now he says that. Well, he said this 5 months ago when there were maybe 100 cases in the United States and we knew very little about COVID, and now we have, unfortunately, hundreds of millions of cases, and we know a lot more, and so our knowledge has changed, and that's part of science. So I think these are, but I think the lack of understanding of that leads to distrust. We need to be very careful. I think through messaging, et cetera, we can try to address these issues.
Yeah. So shifting gears a little bit, maybe we could talk about the interventions, public health interventions and decisions about those. You know, when we look around the world, we see that some other countries have imposed restrictions that I think everyone here kind of intuitively understands would not be possible in this country. How are American values different from values in other parts of the world? How different are they? And how should that influence our response to the pandemic?
Right, so great question. So our values, the way we prioritize and weigh and interpret principles are different, I would say. So in South Korea, for instance, South Korea was very successful in reducing and controlling the epidemic. And there is an app, which everyone has, you can't opt out, that tells you when you're near a person who's tested positive for COVID. And it tells you what the travel and the path of people with COVID has been. So it'll say there's someone with COVID who is in your building, and today this is where he went or she went. So that would not be acceptable in America, I would argue, that it represents, many people would feel too much of an invasion of people's privacy and confidentiality. Similarly, there are in Hong Kong and other areas, if they say you have to quarantine for 2 weeks, they put an electronic wristband on you. And if you, in fact, leave your apartment, the police will come knocking on your door. So that, too, I think, is beyond what America is willing to accept at this point. In some countries, the military has gotten involved. In South Africa, if you don't quarantine, the military shows up. So again, this gets back to what we said earlier about we want to, unfortunately, to curtail autonomy because your autonomy can lead to infecting lots of other people and hurting other people. We don't want to curtail autonomy too much. We want to curtail autonomy the least that we need to in order to gain as much benefit as possible. So I would argue that if we were to say everyone should quarantine, and some people won't, but if 99% of people do without wearing arm bracelets or having the police or military show up to arrest you, that's ideal. So hopefully we won't need to go there. I mean, I think if there were, and I should say, we now know that wearing masks and quarantining works. We see cities like New York and other parts of the country where they've been very successful without having to arrest people or have electronic handcuffs. We've been able to decrease the virus, and the prevalence, et cetera. So I think we don't need to go there. If none of those measures worked, and when millions of people were dying on the streets, then we may need to say no. We need to arrest people, but we're not there yet, thank God.
So speaking of arresting people, right now our society is reeling not only from concerns about the pandemic, but also, of course, concerns about systemic injustice and racism. And this problem intersects with public health issues in important ways. What do you think it's most important for our audience to know or think or understand right now regarding health disparities?
So health disparities are a major problem in our country. They've long been so. I think COVID has exacerbated them and revealed in many ways a lot of underlying tensions that existed. So unfortunately, the data are that African Americans have been something like 3 times as likely to get COVID, 3 times as likely to die of COVID. Latinos, Latinx people have been also much more likely to get COVID, die of COVID. A lot of this is because, and this is for several reasons. One is because they have had poorer access to healthcare before COVID, and therefore have more pre-existing conditions. We know that people who have more pre-existing conditions, if you already have heart disease or lung disease or diabetes, you're more likely to get COVID and to die of COVID, to have a severe case. The same time, when areas, I know New York City best, where when lockdowns began, or there were limited restrictions were put in place, a lot of white-collar workers who were more likely to be white were able to telecommute, and a lot of essential workers who worked in grocery stores, for instance, and were bus drivers and subway conductors, they still had to go to work and were putting themselves at more risk. So I think it's partly, and also, unfortunately, race correlates overall with poverty in this country. And so you have disproportionately more poor people who are African American and Latino, and they have closer quarters in which they live often, not everyone obviously, but so whereas wealthier people could say, well, if my husband has COVID or works in a hospital, he could sleep upstairs or sleep in the garage or sleep in another wing of a house, or stay in our weekend house, or we'll go to the weekend house. Poor people have more people living in closer confined areas, not just in the US, but elsewhere. And so are more likely to get COVID. So I think this makes us more aware of these disparities, and this is something we have to fight. I personally think that these are reasons to have as much, that we need to have healthcare available in an affordable way to people, et cetera.
So I see that we are approaching the time that we're going to open things up for questions. So I think we have time for one more question. And so let's talk, we started by talking about public health ethics in general. Let's go back to that. Probably everyone in our audience is somewhat familiar with medical ethics. I think people are often most familiar with the Hippocratic Oath, which, by the way, is widely misunderstood, as you know. And contrary to popular belief, the Hippocratic Oath does not say that the first principle of medicine is do no harm, primum non nocere. Doesn't say that at all. That's a myth. It's also not true that the Hippocratic Oath is something that doctors swear to. Most doctors don't. It's really of historical relevance and, you know, very outdated document. But anyway, modern medical ethics, of course, are described in a variety of documents, such as the American Medical Association's Code of Ethics, Code of Medical Ethics, I think it's called, which is widely respected and very detailed. And there's also consensus statements, guidance documents from various professional societies, expert groups, commissions, and so on that address specific topics. And of course, the whole bioethics literature. What about, so that's all about medicine and the treatment of patients. What about public health professionals? I think people might not realize that the ethical considerations and the obligations of public health professionals are quite different from the obligations of doctors. So how do those obligations differ?
Yes, so I would argue the underlying principles are similar, but the kinds of problems that are faced by public health departments are different. And as you say, clinical ethics is really based on one-to-one doctor-patient relationships. And the Hippocratic Oath, dating from 550 or BC, give or take a few decades, is about doctor-patient relationships, how I should treat you as a patient with respect, et cetera, and that I should try to help you as much as I can, et cetera. They shouldn't take advantage of you physically, sexually, whatever. These are, and that this is a noble calling, so to speak. It doesn't talk about society as a whole. It doesn't talk about what we do to reduce the health, improve the health of a society as a whole. So that's what public health experts do. And there is a field, as you say, a branch of bioethics, of public health ethics. And there, the problems they face necessitate much more attention to social benefits and social risks. So for instance, with the case of surveillance. So if I have a sexually transmitted disease, I may want to keep it to myself, like syphilis, but in fact, public health departments say no, that they will ask me the names of all of my sexual partners so they can go and find them, because we know that these are transmitted diseases and we want to stop this from being transmitted. Same with HIV, for instance. Also with cancers, we have surveillance. So we want to know if suddenly a bunch of people at one intersection start dying of cancer. We want to know, because that means maybe there's something at that intersection. It's whatever it is. There is, you know, toxic wastes that are there or something, or, you know, if there's a particular neighborhood where lots and lots of people are suddenly dying of a cancer, we want to know that so we can prevent it. So therefore, we're going to get lists of who has cancer and where they live, so we can follow things like that. Now, ordinarily, I may not want information, the fact that I have cancer, to be known to anyone. But in the name of public health, we say that the good of the community as a whole dictates that that information is given by my doctor to a confidential registry. So these are kinds of examples where, in the name of public health, and protecting the health of the public as a whole, we may need to, again, curtail individual rights. Obviously, we don't want to just publish in the newspaper, here's everyone who had syphilis, here's everyone who has cancer. It goes to a confidential, very carefully watched registry, but the goal is to prevent these diseases from spreading more widely. So it's important to realize that there are different priorities that are given. It's less the responsibility to the one patient, but more responsibilities to society as a whole and their health.
So I would love to continue this conversation, but I wanted to pause to see how we're doing with time. And Kambiz and Miyako, do you want to go to the Q&A or should we continue?
Yep. Hi, I can jump in. This is Miyako. I'm the club admin for the Columbia Club. Everybody who's listening, if you have questions, go ahead and type them into the Q&A function, and then we can ask them for you. Since we do have over 140 or so members, we don't want to open up the questions to asking live, but we can ask your questions if you type them in. And so what I can do, Ellen and Dr. Klitzman, if it's okay, I can start with a couple of them and then see how many come in, and then Ellen, I can hand it back to you at the end.
Okay.
Sounds good. I see there are a few questions so far, it looks like.
Yeah, and so we have a couple of questions, I think, that people are concerned about how information is given by public leaders. So what advice would you give leadership in terms of how to effectively communicate the importance of some of these public health measures? Because it is so politicized, and we saw this at the beginning with mask wearing, where we didn't really know whether masks would work, and now we know that we really should be wearing them, but people have this previous history from the beginning of the pandemic. So how do leaders communicate that efficiently over time with new information?
Right, great question. So I would say, first of all, as Ellen mentioned earlier, that good ethics starts with good facts. I think good policy starts with good facts as well. So I would argue that leaders should be informed by the facts and by leading scientific understanding. And as Ellen mentioned earlier, there is scientific consensus on many, many aspects and issues at this point concerning prevention. At the same time, there needs to be transparency. It needs to be clear what we're doing, why we're doing it, what the reasons are, how the facts support this. And I think there also maybe needs to explain the fact that there's uncertainty, that this is what, according to our understanding now, based on where we are, it could be the beginning of the epidemic or wherever we are, that this is our understanding, and that may change. The analogy I sometimes use with students is I think of Christopher Columbus. And if someone asked Christopher Columbus in the year 1500 what he found, he would say, I found some islands off the coast of India. And it took, 400 years later, 300 years later, Lewis and Clark are still trekking through parts of America and finding out that, in fact, there were, obviously, Columbus found continents that were not India. And that even 300 years later, we were still discovering, who lived there, what the land looked like, where rivers went, what rivers there were. So there is a process. It takes a while, and no one likes to hear that, but that's the fact. And it's like saying, if you want to learn how to fly an airplane, you don't expect to go up today and fly the airplane this afternoon if you've never flown an airplane before. It takes practice, etc. So I think people, I think that the notion that there's uncertainty, there's something we're doing our best to work on, I think, and reducing. I think these are the kinds of messages that are needed.
I think those are really great points. If I could to just add to that, I think that as in as a leader or as a public health policymaker or any health policymaker, uncertainty is one of the most difficult things to deal with, because often you have to make policies that you know might be wrong. You have to make decisions based on incomplete facts. And I think it's really important to kind of factor into your decision making the effects of a wrong decision. And, you know, as the questioner mentioned, you know, if a public health official says one thing and then they say the opposite, you know, first they recommend masks, then they don't, or whatever. And especially if this shift is not communicated well, the rationale or what changed is not communicated well, people just tend to lose trust, or they develop, you know, theories about the motivation that aren't true, and they really just lose faith in this being about the science. So I think, you know, when you make policy, you have to think, or actually same thing in medicine, if you make predictions about prognosis and you say this patient is, you know, never going to make it out of the intensive care unit, and then they make it out of the intensive care unit, that patient's family is not going to trust the doctor the next time they say they're not going to make it out of the intensive care unit. So I think it's really important to be humble and to, as Bob mentioned, you know, acknowledge the uncertainty.
Great, thank you so much. And we have a question now from Linda DeGudis, and she says, how do you define public health? From the standpoint of a public health professional, while we look at the issue, the social issues related to health, we're not all working in health departments. And for those of us who work in injury and violence prevention, we're constantly questioned about why these are public health issues.
Great question. So I would argue that violence and injury prevention are very much public health. So public health is misunderstood, I think. It's not just about what what is the definition of public health is the health of the public as a whole, right? So the point is, it's not just about individual health of what's best for me, whether I should take this medicine or that medicine, but how do we help the health of the population? So obviously there are a number of different ways that this comes into play. There's infectious diseases, there's different kinds of infectious diseases, there's chronic diseases, there's injuries, there's mental health issues. Public policy affects health in a number of ways, and particularly we know now that there are social determinants of health. We know that people who are poor, people who are homeless, people who have mental health problems are more likely to have physical health problems as well as a result. These are all concerns within public health. So I would argue that people who say, well, injury prevention is not part of public health are mistaken. I think part of the issue is that public health is a relatively new field. So as we mentioned with the Hippocratic Oath, written, 2,500 years ago, the notion that I doubt the Athenian government had a public health department. They had the plague, and there have been plagues that have devastated many cities and areas in Europe and China and throughout the world over the centuries. But the notion that it's government's responsibility to take care of the health of people, even if there's not a plague, is a relatively new concept, or it's not been as robust as it until recently. It was in the 1800s, I think, there was very seminal work by John Snow when there was an outbreak of cholera, I believe, in London, and he took a map and mapped where they were, and they were all around one water pump. It turned out that one woman had washed her infected baby's diapers in that pump, and everyone who got the water then to drink got cholera. And that was a great beginning of public health, of saying, let's map where in a population, where in a city are there cases of disease, and that can help us treat the disease, rather than relying on each of those patients then seeing their doctor, if they could afford a doctor, who could then try to come up with a treatment. Public health is often about prevention, about saying, what are the underlying causes? Is it from an infected pump somewhere, and trying to address those issues. So I think public health is new. It's a huge area. It needs much more attention. It too has been under siege. Obviously, having effective Health policy affects public health. Obviously, there have been huge debates over the Affordable Care Act, its future. These are major public health issues as well. I think underlying this, there are certain questions. One is, to what degree is health a human right, and what does that mean? Many of us believe that healthcare is health, and a degree of healthcare is a human right, and we as a country have not yet decided how much healthcare is a right for everyone. We are one of the only, if not the only, Western industrialized country that doesn't have nationalized healthcare in some way. Many of us think that's important because that will help the health of our country, but we are divided in our country about that. And that's one of the major issues in public health today.
I'm going to combine a few questions if I can, and then I'd love to get both of your feedback. In America, we have a lot of things in our lives that are regulated, but right now, mask wearing and contact tracing, we're just really not getting full cooperation from the public, if I can say that. And so Stacy and Mark Comrade are saying, should there be any legal coercion involved in the contact tracing process? And also looking just kind of at the current administration, we can't necessarily expect them to change their approach. So what is kind of our backup plan for us to protect the health of our communities without that leadership from the federal government? What can we do in our communities?
Well, great question. So one, of course, is the federal, we still live in a democracy, knock on wood. And so everyone, if you disagree with what the federal government's doing, we should all vote, however you want to vote, but not to be too partisan, but voting is important. Certainly there are state leaders who have been playing major roles. Some state leaders have done very good jobs dealing with COVID. Some state leaders have not done very good jobs, and you can just look at how the epidemic's performing in their state or spreading in their state or not. And again, our votes matter. I think that we know also, though, that social behaviors are spread. So I think that if we all do wear masks, if we tell our friends, families, loved ones, others, co-workers, et cetera, to socially isolate, to wear masks, to give feedback to each other, that's important. There are important group norms here. I was at a birthday party just a few weeks ago, and I was the only one who came in wearing a mask. Some people had a mask in their pocket or around their neck, but it was a little bit uncomfortable wearing a mask. People sort of looked at me like, do I not trust that they're healthy? This actually was in Pennsylvania, where the cases are not as, in areas where the cases are not as high as New York, but there's still some cases. So there's almost a stigma of wearing masks. Certainly, Ellen asked earlier about values. Well, China and Japan, Hong Kong are countries in which if you went on the subway anytime over the past few years, you would see people wearing masks because they had the common cold, presumably, and didn't want to spread it to other people. That's something that would be seen as being sort of weird here in New York or in the United States, in DC or elsewhere. If someone was on the DC Metro months ago, a lot of people wearing masks would not know what to do or wonder what's wrong with them. Maybe they have a really serious disease. Maybe they have tuberculosis or something. So again, values play a role here, but I think that values and our policies should reflect what we as a people think should be the case. So I think that ideally we should be concerned about our health, public health, and I think our leaders should be supporting that, and we should vote or encourage or write letters or apply pressure to them to have them do what is in our interest as a community and as a nation.
You know, I am struck by how there's been such a tremendous emphasis in this country on lockdowns, on, you know, restrictions on work, the workplace, public facilities, people not being able to travel freely, etc. And so little emphasis on, the question was about contact tracing, but I would add to that testing. And I don't really know why that is, but it's quite remarkable because when I look at the effectiveness of various public health interventions, the only reason we have lockdowns, we being any country really, is because the epidemic gets out of control and someone is knocking on my door, and I'm going to ignore it. The epidemic is out of control. And therefore, you know, it's a last resort really, and a tremendous imposition on people's personal lives and their freedom. Whereas testing, well, contact tracing really isn't that helpful if you don't have effective testing. And we right now in this country, our testing is ridiculous. I don't know whether people really appreciate just how bad it is. But I've been recently helping some schools with their colleges with their back to school plan, and high schools also. And what they want, and workplaces too, and what they want is a test that is fast, accurate, cheap. The fast part, when I started looking at this back in March and April, we were looking for fast being, you know, within hours. And I was thinking, that's a pipe dream. Maybe that'll happen in the fall sometime. I had no idea that fast now means like 72 hours after you're tested. People aren't being tested until they develop symptoms. Symptoms don't occur until a few days, typically on average, into the disease when you are infectious for 24, 48, 72 hours. And we know that a large percentage of people aren't even getting symptoms, probably in some studies more than half. So the idea that we're only going to test when you develop symptoms, and because there's a big delay in getting the test after you develop symptoms, people don't wake up and go, oh, I think I have a little bit of a cough, I'm going to go get tested in 5 minutes. There's a delay. So by the time people are tested, Bill Gates said this a few days ago, most of the testing that is done in this country is completely useless. And if you're going to do contact tracing on people who essentially are no longer contagious, you're going to find people that perhaps they infected a week ago or more, and those people may have already infected someone else. So you can see how it's, you know, it's really not an effective strategy to do contact tracing if you don't have rapid turnaround for testing. In my area, I've been working with the president of Vassar, where my daughter's in college, and we just did an article on modeling the testing frequency that would be required to keep students safe. We can't get the tests that they need. They had a requirement that everyone needed to be tested before arriving at school. After a lot of debate, it was determined that that test could be up to 7 days before, which really is, if you're testing 7 days before, it's almost worthless at that point, because people are actually only contagious for something like 8-10 days, we think. So, but anyway, no one could get the test within 7 days. In my area, I personally, my daughter had to do a mail order test from someplace in California, because there was no place in my entire DC region that we could get a test that was reliably coming back within 7 days. That's how bad our testing is. We essentially aren't testing. So I think that's really probably the priority if we're going to not have lockdowns and continued high rates of disease.
So I would agree on that. I would just add a few things, and those are all great points. So one is, we were not adequately prepared as a country for this pandemic, and we should have been. We had H1N1 as an epidemic a few years earlier. There were recommendations that we stockpile personal protective equipment, ventilators, et cetera. And prevention in general is hard to do. People think, why spend money on something that hasn't happened yet? So we were underprepared. In fact, it was known when SARS-1 occurred a few years ago that fruit bats had already develop other coronaviruses, other COVID viruses that would attack humans. There were researchers who said we need to start working on this now, develop vaccines. They could not get funding for this because we have focused too much also on dealing with the here and now rather than future problems. And I think that this is something we need to think about as individuals, as communities, as voters, as a country, on also getting ready for the next pandemic. I think also, again, politics played a role here. So early on, when there were scientists saying we need to develop tests and start rapidly testing people, there was tremendous pushback from some politicians who said, forget testing, I don't want testing. You know, we, both in states and nationally, of course, if you don't test, you won't find any cases and you can say there's no epidemic. And so there was, testing itself became politicized as a way of sort of COVID denialism being a factor here or part of that. Another problem with testing actually at the moment is, first of all, as Ellen was just saying, there are huge delays in many areas to get tests, especially in the beginning where it was said you can only get a test if you had symptoms. And of course, now we know that people without symptoms could have COVID as well and be spreading it, even if they're symptomatic. But there's an issue with false positives and false negatives. There's still a lot of false positives, false negatives. I think this is one of the areas where there's uncertainty, and I think it also leads to distrust. The governor of Ohio, for instance, at first tested positive, then a week later tested negative. I think stories like that, without understanding the science or why that's the case, lead to further distrust. I think there's not been enough transparency about the problems with testing, why there's such high rates, et cetera. And I think also we need to invest more in science for future epidemics as well, which is something we've not done well.
Yeah, I think that's a really great point. I mean, with regard to the sensitivity of tests, I think there's so much misunderstanding out there, even among the medical community, I think, because, you know, people have a general sense of what sensitivity means, you know, that that there's going to be a low rate of false negatives. So if you have the disease, if there's a high sensitivity, if you have the disease, it's very likely to be a positive test. You're not going to miss very many people. And that's so important. So, but some of the tests, it's fairly predictable that certain tests are going to have a lower sensitivity. So for example, right now there are antigen tests for diagnosis as well as molecular tests. And the molecular tests can be PCR tests or non-PCR tests. And the PCR tests are the gold standard, but these other tests have a role and they have lower sensitivity. But what that means, really, I think people think, okay, if it has a 70% sensitivity, that means you're going to miss 30% of cases. What that really means, though, when you put it in context of the disease, is that it's thought that when you get infected, your viral titers rise very quickly over the course of 2 to 3 days. And during that period of time, there's an exponential increase in the number of virus particles. And then people peak around before the symptoms would develop, if they are going to develop, or soon after the symptoms are going to develop. And then the titers stay high for about several days or maybe up to a week. They're falling by a week typically. And the degree to which you're infectious is based on how high your viral titers are. So these people that have very low titers, they're infected, but they haven't, you know, climbed up that curve yet. If you have a test that's 70% sensitive, it means that it's only going to detect the virus if it's this high. So it's going to miss those people before they become symptomatic, but it's going to catch 100% of the people that are here. So when you see these 70% tests, and I'm generalizing a little bit, but when you see these 70% tests, it's overall they're missing 30%, but they're missing the ones when the titers are low. And when the titers are low is when you're least infectious. So those often have a real role, especially if you test frequently, that you test people at the time and you find out if they have a high viral titer, especially if you're testing daily in the workplace, you can remove people from the workplace. And those sorts of tests are coming. Right now, I'm heard that there's this test from Harvard that's predicted to be available in 2 to 6 weeks, which is essentially like a pregnancy test. You're going to spit on a little strip, and the sensitivity is going to be lower than PCR, but you can do it every single day. And they're talking about it costing $1. So think about what a game changer that would be if every day you could determine if you had a high viral titer. Yeah, you're going to miss the people, you know, that don't have the high titer yet, but complete game changer.
Of course, you'd have to get people who are willing to take the test, because there are people who may say, I don't believe any of this stuff, or they don't get tested or don't want to get tested, et cetera. But you're right. I think it would be if that's the case, it would be a big game changer. Absolutely.
Okay, we have a few questions about, I guess, contact tracing and more. If you could just really briefly say what causes a false positive in a test, and then move to the thought by D. Liu, if we limit contact tracing, are we not limiting the usefulness of testing?
So I would say for the second question, you limit the usefulness of testing, but not completely. So I think testing is still important, because if I find out I'm positive, hopefully, even if you don't find out whom I've been in touch with and get in touch with them, that I will protect myself more, one hopes, from infecting other people. So if I find out I'm positive, hopefully I will say, you know, I think I won't go to the family dinner tonight. Whereas if I didn't test positive, I might go anyway, think, hey, I feel pretty healthy, or I just had a little sniffle this morning or something, or just a headache. So I think that testing could still be important without contact tracing. However, contact tracing would obviously help, because let's say I go to school and I find out I'm positive. Well, if there's contact tracing, I find out I sat in a classroom with 30 kids, we can then know to test those 30 kids, whereas I might not ordinarily say, hey, these 30 kids all need to be tested. I might not disclose the results of my testing or to people who may nonetheless have been exposed.
And if I could just jump in, Kathy asked that, she says the school district in her jurisdiction is resisting alerting parents if another student or employee tests positive. So what would that impact be?
Well, that's very unfortunate. And I want to say that's probably a red state, I would guess, or a red area. So that makes no sense. I think parents have a right to know. And again, this is public health. Public health ethics dictate that if my child was exposed, let's say someone in the class has it. Well, if they keep going to school, they may continue to get it from other kids in that class, or I may sit 5 seats away from Johnny who had it, and Johnny may give it to Sally, who gives it to Sarah, who gives it to me. So it may not even be the one kid that I get it from, but the one kid may affect other kids who affect other kids, et cetera. And of course, the kids come home and infect other people. So I would argue that parents have a right to know that my child was exposed. I could get my child tested, and I can decide, look, I have asthma, or I have a heart condition, or whatever, or I live with my elderly grandmother who's at increased risk of dying if she gets COVID. And so I may decide my kid shouldn't go to school as a result. I think these are very serious issues that we need to take very seriously.
Yeah, I think it's important to distinguish between, you mentioned alerting the parents that a student at the school tested positive. And that's very different from alerting an individual that they had an exposure to a specific person that was positive. So let me take those separately. With contact tracing, that's what you're doing. You're asking the infected person about their exposures. And the definition of an exposure is not any contact. The definition of exposure is actually very conservative, and it is, depending on the state, it's typically 10 to 15 minutes within 6 feet of somebody with no mask. So, you know, it's not the class being in the same class. It's not, you know, passing them in the hall. And so if somebody meets those criteria for exposure, which is, you know, pretty, as I mentioned, conservative, but it's pretty widespread in terms of what the CDC recommends and so on, what will happen is, what's supposed to happen is that the local public health department will interview the person that's positive and then contact the people that had the exposure, but they will not disclose who. They are keeping confidential the name of the individual that had it. So if you had this happen, you would get a phone call that says you have been exposed, but they will not give you any information about the circumstances or who you were exposed to, because that's all confidential. So that's the normal contact tracing process. That's very different from whether or not a school is going to publicly disclose to all members of the school community the number of positive tests they have. And that's not a public health issue in the same way, and not in as direct a way, at least. You know, I've been watching Vassar with great trepidation because they are publishing their number of tests and their positive results, and it's very nerve-wracking watching this when you have a kid up there. But not everybody's doing that. That's it would be nice, but it's I would say not obligatory. A lot of schools aren't doing it.
So I would say this is going to become a huge issue for the following reason. So there are schools that are opening up, obviously, and there is the whole, we haven't talked about this yet, but it's very complicated issues. And again, as Ellen was said earlier, dilemmas ethically are not between good and bad. It's between their pros and cons of opening a school, right? On the one hand, education is important for kids. Kids can socialize with each other. They can learn in the classroom. Many kids, particularly younger kids, will probably learn better in a classroom than they would if they're at home. But there are risks of infection. And I think it's going to be a big question. At what point would a school say, we've opened up? We see this with universities now. So University of North Carolina and a few other schools have said, we opened up and found that we now have hundreds of cases, so we're going to close. What is the number of cases for which a school, whether it's a high school, elementary school, or college, should say we're now going to close? Presumably, if it's one case, we may not say, well, we had one case, we're going to close, but it's not clear to me what that number is. And that may be, again, obviously depends on the size of the school. But I think this is an area that going to need a lot more attention. I would also say that I agree with what Ellen said. However, just to be clear, one can still be exposed and get infected even if one has had less than 10 to 15 minutes of exposure. So if I have COVID and I sneeze could go 20 feet, 25 feet. And if I breathe in a sneeze and I'm there for 1 minute or 1 second and am 10 feet away, I can get infected. So I think obviously that may not be in the definition of contact tracing, but it could in fact lead to someone getting infected, just to be clear.
Yeah, I think that's an important point. I don't know if everyone understands that point, if I can just expand on it a little bit. I mean, the reason for this 10 to 15 minute criterion is that in general, viruses, take the flu, which is well studied, there's a minimum infectious dose. And so 1 viral particle or 5 viral particles does not cause infection. Kind of counterintuitive. I think people think if I get it, it's like there's one and it got me. You know, it's not, you know, there has to be a certain amount of particles that not only hit you, but penetrate the areas that, you know, are required to become infected, which is basically mucous membranes. Mouth, nose, and eyes are now, you know, getting a lot of attention with masks and eye coverings and so on, because there seems to be transmission that way as well. So if somebody, yes, theoretically, absolutely right. If somebody coughed a big enough loogie on you and it went right in your mouth, absolutely you could get affected. But it's unlikely because more often it's repeated breathing in small amounts over a period of minutes that gradually increases your exposure to the point where you reach that threshold. So that's I also say that the data on this is not good. There's not a lot of information about, certainly we don't know what the minimum infectious dose is. We're basically generalizing from how other diseases behave. And looking at studies of transmission and the characteristics of people that got infected by other people. And what we're seeing is that, it's very often family members living in the same place. It's enclosed spaces where people spend a lot of time. So you're not seeing a lot of transmission. It's very rare to see transmission from somebody that you only saw very briefly in passing. I don't know that there have even been, reports of that. There's usually an explanation that there's a more prolonged exposure. So that's, but it's really not known yet.
Yeah, I think that's a key point, is that, there's a lot that we just don't know yet that hopefully we will. I think also the fact that apparently the virus can stay in the air for longer than a lot of people would like is an issue. Should we go to some of the other questions?
Yes, if we have some questions around COVID denialism, and I don't want to spend too long, but the president has said if we didn't do so much testing, we wouldn't have so many cases, and a lot of people claim that no one's died from it or it's a political hack, and if you challenge them, they just really double down. And this kind of goes back to science education in kind of middle and high school, and having people have a better understanding. So what can we do as individuals to promote science literacy?
Right.
All levels, education and as adults.
So great question. So a few things. So one is are things that scientists themselves and science teachers need to do. So science can be fun. I think a lot of science education is still memorization based. Memorize, Boyle's Law or something. And in fact, if you speak to scientists, many of them had activities that made science fun for them. I remember I took a science course once on Long Island through Cold Spring Harbor Labs on Long Island geology, and we got in a school bus and drove around Long Island and saw all kinds of geological formations. I was right after 7th grade. It was fun. So I think that we can make science fun. And I think that this is a major challenge that school districts and others need to get involved with. I think in terms of science denialism, you're right. Some people double down, but some won't. And I think that the fact that science denialism exists doesn't mean we shouldn't try to challenge people who have misinformation. We need to do it respectfully, of course, and it's sensitive, but we should still try. If we come across people who say, well, I don't believe this stuff, we should try to engage them, I think. And I think we could all be science educators. Presumably the people here went to Harvard, Yale, Princeton, or Columbia and are smart, and I think could probably be good at convincing a number of people. We may not convince everyone, but if we convince some, I think that will be a good start.
And then we have, I'm going to combine questions again, but health issues can really be pushed for by multiple policies in different industries, not just public health professionals. Like civil engineering could bring clean drinking water into big cities and help reduce wealth disparities. And along that, is there any kind of technology, we might be opposed to putting some kind of tracking thing on our phone, like an app, to follow us, but is there something in technology that could really help reduce inequalities in public health?
Yes. So a colleague of mine at Columbia in the School of Public Health, for instance, is doing work with inner city mothers. This is pre-COVID, but sending them a text message on their phone about getting, checkups for their kids or getting vaccinations for their kids. Your kid it's time for the kid's vaccination. It turns out that the mothers the studies have shown that she's done, have been much more likely to engage in preventive health behaviors for their kids when they get reminders like that. So I think that using the technology is important. Telehealth is a whole other huge area, obviously, where there have been devices that have let doctors and nurses monitor people at home who in the past may have had to be in the hospital, but where gadgets that could hook onto a phone that could measure respiratory rate or even oxygenation or blood glucose levels or other kinds of things. So I think that technology can play a huge role in helping to address health disparities. People who may be too far to get to a hospital may not be able to have time or to get to the hospital because they're having to take care of kids at home. I think that technology can absolutely help address a lot of these issues.
And
If
then,
anyone wants to jump in at any point, obviously, feel free.
yeah.
That's okay.
Okay.
I'll wait for this.
I think that a lot of people realize that there is potential for opportunities here moving forward. So what can we learn and take away so that this isn't just a negative where, you know, over 170,000 people died? What can we learn from and put into work in the future?
Right, great question. So I would say on the one hand, obviously, wear a mask, socially distance, tell your friends and family to do so as well. I think if we all did that, if everyone in the country did that, the epidemic would go away. As Ellen said, this is, there are things that we can do. This is not just by looking at someone, I'm not going to give them COVID. If everyone wore a mask and washed their hands, et cetera, and socially distanced, the epidemic would go away tomorrow. So there are people who are not doing this. I think that we all should work on getting others to do it as well. And I think also voting, if there are leaders at whatever level, national, federal, local, who have not been responsive, who have engaged in COVID denialism, or have not been responsive to the needs of voters, I would hope that we all as voters would help ensure that our future leaders are concerned about our health, our public health. And we all have the power we have an election coming up in just a few months. We all have a power to do that. I think that's important, however you want to vote. So I think that those are some of the things that we can do that I think would be effective. And
Yeah,
speaking to others about it, if we see someone not wearing a mask or who we know, then I think talking to them about it.
You know, being an optimist, I think I like to interpret that question as what are the silver linings of this situation we're in? And I think there are a number that are hard to see sometimes, but when we take a step back, I really think there are. First of all, we have seen the most amazing rate of scientific discovery and innovation and advances that we've ever seen in the world ever. It's truly remarkable, the speed with which scientific knowledge is advancing and the speed with which we're developing not only vaccines, but tests, treatments. I mean, there are hundreds of tests that have been developed that we are just accelerating the rate of development in all kinds of technological areas. And people are coming together to do things in groups. So there's a group in Massachusetts with all the, the hospitals of all the different schools in Massachusetts that all come together to work on these scientific questions. We're seeing collaboration in ways that we've never seen before. I also think something like the challenge of, I think, again, about my daughter in college, and many of you, I'm sure, have loved ones that are either going to school or going to the workplace and trying to figure out how to manage these problems. They are learning a certain set of skills, and President Bradley for Vassar actually said this, so it wasn't just my idea. They are learning to work together in ways and to sacrifice and to learn how to talk to each other in positive ways in order to help change others' behavior and try to reduce conflict so that groups can achieve a common goal. And I think that's going on all over our society right now in sort of microcosms of, groups of people who are trying to negotiate these very complex issues. Yes, there's a lot of conflict, but I'm also seeing a lot of cooperation and people working together in ways that they never have before. And the other thing is, I think, I can speak for myself, and others may have similar experiences. Things like this make you really appreciate your privilege and what you have, and be grateful for the little things, and to really focus in on what's important in life. I think crises help people re-examine things that they take for granted, and I think that's a good thing.
And I would just add along those same lines too. I think obviously there's this enormous stress that we all feel, isolated, taken out of our routines, not seeing and interacting with people the way that we like, not being able to do things that we like to do. But I think people have been creative. They've often reached out to people they've not been in touch with in years, through Zoom, through phone calls. And I think that things like that are other positive aspects of this, of having to make an effort to reach out to people, but therefore doing so. So I think that there are positive things, and I think we're all learning something from this. People have also watched a lot of good movies lately.
We have a few people asking if this will be shared, and we are recording, and once we have processed it, it will be posted on ColumbiaDC's YouTube page for everybody to watch again. And as long as it's okay with Bob and Ellen, you can share with your friends and family, students, etc.
Absolutely, that'd be terrific.
Great. And then maybe just one last question.
Yes.
If we want to read more or listen to more on this topic, are there any authors or journalists or books, podcasts, movies that you might recommend for us to just learn more?
Yes, so I know there's a lot written. I've written a few pieces. I can send you links if people are interested in that. I think that the New York Times, the Washington Post, the New Yorker have all written good pieces on this. Of course, scientific journals as well, but it's a great question. There are not yet many books on this. I think it's still too new and evolving. But again, I would trust reputable sources. I can send you some links, things I've written, so other things that other people who've written that I have found to be interesting.
That would be great, and we can share that with the YouTube link as well. Ellen?
It's such a broad set of topics. So many things are swimming through my head. To understand the science, there was a series that I thought was very helpful that I often recommend to people on the platform Medium, which I've learned about all these, open source publications now, because in many cases they're becoming very valuable. And so those are the things that come to mind. Do you want us to send links to?
It would be great, Ellen and Bob, if we can send, as we send the recording of this, we can send links to people. I would say that my top source of information comes from the movie Contagion, which is accurate, right? So but thanks so much, both you, Bob and Ellen, for spending time on this important topic, and it has been an education, and I appreciate your time.
Great, you're welcome, my privilege. I would just add two other things to read, by the way, if I can, very quickly. One is, there's a classic book called Plagues in People, which was written in the late 70s by William McNeill, who was a professor at University of Chicago. It's one of the best study or books about the history of plagues through humankind and how people have responded over the centuries. And so, for historical perspective, you might look at that. And then there are a number of works of literature that have looked at plagues pre-COVID. One, the most famous perhaps, being Albert Camus' novel, The Plague. Daniel Defoe, best known for Robinson Crusoe, wrote a book, Journal of the Plague Year in London. But they're sobering to see how plagues have affected other societies and brought them to their knees. And yet, of course, they've in the end recovered, as I'm sure we will in some way as well.
Right. If there's no comments, no questions, thanks so much. And hopefully we see you at other events.
Thank you.
Bye.